morning. Danielle Bennett out of Baton Rouge. Go Tigers, by the way. Just so you know that. All right, so this is, again, it's silver impregnated absorbent pads can be a cost-effective strategy in the care of Stevens-Johnson syndrome and toxic epidermal necrosis patients as compared to a non-adherent silver impregnated foam dressing. What I really wanted to call it was dressing choices and how to save money, but I figured I needed to expand a little bit on that so that they would accept my presentation. So I do have a financial disclosure. Travel accommodations were provided by Silicone. So historically in our institution, for SJS and TENS patients, we've used the silver foam dressings, which I'll try to refer to as silver foam dressings and then silver pad, a little easier. We found great success with this dressing for the past 15 years. But we did find that over time, if you start using these on large surface areas, they become quite costly. This is just your silver foam dressing. Now, we'll disclose that these are stock photos from the manufacturer's website. Our institution is very good at taking photographs of wounds, but when I go back and look, we don't really take photographs of dressings. But new choices have come to the institution in the last couple of years with the choice of a silver impregnated absorbent pad in the treatment of SJS and TENS. Larger sizes are now available. They tend to be a little bit less time consuming with dressing changes, but with any new product, you always have some sort of a learning curve. There we go. And so this is application of the silver pad dressing. So this kind of posed a question to us, and with our verification brains thinking is there room for improvement? And the answer is always yes. So what we started to do is we started a performance improvement project, and it went through our burn products committee that manages all of our burn-specific products. There's two questions when any product comes through this committee for us. The one thing that we ask is it cost-effective to make a change? And then what product would it replace? So I've come to this meeting for many years in the past, and Dr. Dimick was always adamant at saying that if you weren't trying something new every 6 months, then you were falling behind. So with that philosophy, we forged forward. Are these two products comparable? And the answer is yes. They both have similar indications for use. They were both 7-day dressings. They both can actually be cut or altered without messing up the dressing itself. And then they both had a silver component to it. So then the administration says, well, how much is it? So cost per square centimeter was not a significant difference. However, when you started looking at the dressings, the size-wise of how they come was a little bit different. So it took 5.5 of the foam dressings just to be equivalent to one silver pad. So when you start looking at that cost to the institution, you did start to have a little bit of a difference there in the cost overall. So I started doing some chart reviews and some digging. Fun times. So what were we looking for? So we started looking at the total amount of the base dressing that was used with each dressing change. We started looking at whatever secondary dressings were used. And then I started looking at the overall cost per dressing change to the institution and the overall cost for dressing change to the patient. I was able to dig out and I found two patients that were very similar in nature. First was a male patient with diagnosis of TENS. He had a body surface area of 1.94 meters squared. He was approximately 90% sloughed, and he was dressed primarily in the silver foam dressing. The second patient was actually a female patient, same diagnosis. Her body surface area was 1.92 meters squared. She was approximately about 100% sloughed, and she was dressed primarily in the silver absorbent pad. This is where it gets interesting. So the first patient in the foam dressing, if you look to the far left, these were the actual dressings that were used. So the primary base dressing, we had 10 of the 8x8s, we had 23 of the 8x20s, and then the secondary dressing was your netting, your gauze, and your fine mesh. We all know that there's a significant upcharge from the facility, so that was a little over $10,000 charged to the patient. From a facility standpoint, those same dressings ended up costing us a little over $1,800. But I looked at this and I was like, why are we using so many dressings? That's a lot of dressings on our patients. So again, I'm doing this retrospectively. So I went back and I looked and I said, we technically had to cover someone who was 1.94 meters squared, but we ended up trying to cover someone who was 2.79 meters squared. So going back and doing a little digging, manufacturer recommendations say that you need about a 1-inch overlap for the foam dressing for it to be effective and stay in place. So then I said, let me ask our techs. We have techs. I know they're a dying breed, but love them dearly. I said, how do y'all do your dressing changes? I'm having this overage that's coming in, and I said, where can I account for it? So hands and feet were thought to be where we'd lose a little bit extra dressing here because you require more with the cut and the wrapping and whatnot. And then there was also soilage if someone had a bowel movement during the process or within that 24-hour period, because I looked back at charges is how this went. Also, if they opened a dressing and needed a small piece, but yet didn't need the whole piece, that whole dressing was charged to the patient. So therefore, what was not used was, again, saved for a different dressing change, but it went on the charge for that day. The second patient, which was the silver absorbent pad, if you can see to the far left, again, there was 5 adaptic rolls used, a skin stapler. There was 8 silver absorbent pads, and then the outer dressings were your fine mesh and your netting. That came to a cost to the patient for about $4,300. The same dressings to our institution was a little over $800. So again, we used a lot of dressing still on that patient. So again, why are we dressing so much? Same concept. It was a 1.92 meter squared patient that we needed to cover, but we ended up covering almost 4.46 meters squared. Asking these questions to our techs because there are no manufacturer guidelines for overlap on this dressing by the manufacturer. It was this dressing actually does a lot better. And of course, this was new. We had a learning curve to using it with a lot of overlap, so it can be secured nicely and then stapled upon itself to the other side of it. So I felt a little better after asking them, but I think we can do a better job. Significant cost change as far as what I could find for us. So the silver foam dressing at $1,800 to the institution versus the silver absorbent pad at $800 to the institution would save us roughly $1,000 per dressing change. So looking at it also from a reimbursement standpoint, we all know that dressings usually are not reimbursed. They get tied into the DRG of the hospitalization. We still just try to figure out, in the grand scheme of things, if we were to get reimbursed for this, if we use the 16 cents on the dollar for Medicaid reimbursement, how would we minimize our loss? And so therefore, we still take a loss on both, but there is a little bit less of a loss with the absorbent pad. So what we did find was that the overall cost for these dressings, that the silver impregnated pad is more cost effective than the silver impregnated foam dressing. It roughly was about 45% more expensive for a foam dressing than the silver pad. So what are we going to do with this? So we're going to keep looking. We're going to decide. There's actually, since this presentation or since this data collection was done, there's more size options for the silver pad that we can now use, and we can look at the comparison of, do these changes in size go to more cost savings to us, or are they cost prohibitive to us? And then actually, is there an overall difference in the patient outcomes between these two dressings? So, any questions?
I'm Stephanie Campbell, the Burn Program Manager at Parkland Regional Burn Center, and as he mentioned, I'm presenting this project for Amy Gloger, who was our burn nurse educator throughout the duration of this initiative. I have no disclosures. So a little background, we all know that delirium is pervasive in ICU patients, some studies reporting it up to 83% of ICU patients in the general population, and then a couple of studies that looked at burn patients in particular identified it in 77% of ventilated patients and 14% when you included non-ventilated and ventilated patients. And we know the long-term impacts of delirium can be serious. Physical disability, cognitive disability, unemployment, and even mortality from long-term complications from delirium. The confusion assessment method for the intensive care unit, the CAM ICU, is the gold standard in delirium assessment. It's a validated tool that many hospitals are using today. If you're unfamiliar with the tool, it basically assesses 4 features: the acute onset of fluctuating mental status, inattention, altered level of consciousness, and disorganized thinking, and here's a kind of flow chart to help you see how that works. So for feature 1, acute change or fluctuating mental status, you basically decide, has there been an acute change in the patient's baseline mental status, or has the patient's mental status fluctuated in the past 24 hours? If the answer is no, then their CAM ICU is negative for delirium. If it's yes, then you move on to feature 2. Feature 2 is inattention, and the way you assess this is you actually ask the patient to squeeze your hand when they hear the letter A, and then you repeat a specified sequence of letters, which basically spells out save a heart with heart spelled incorrectly. Once you do that, if they have 0 to 2 errors, then their CAM ICU is then negative. If they have greater than 2 errors, then you move on to assess feature 3, which is altered level of consciousness. You can look at the patient's RASS score, their Richmond agitation level, and decide if they have a RASS score other than 0, then their CAM ICU then becomes positive. This is what we utilize at our facility. If their RASS is 0, then you move on to disorganized thinking, the assessment of disorganized thinking, where you ask the patient a series of questions like, will a stone float on water? If they are intubated, you can ask them to perform a command such as hold up 2 fingers, and then you ask them to progress by either adding another finger if they have trouble moving both arms, or now do the same thing with the other hand. Again, if they have greater than 1 error, then their CAM ICU then becomes positive. 0 to 1 errors, the CAM ICU is negative. So you can see even just the basic description of that can lead to some confusion over using this tool to assess patients in the ICU. A little background of what was going on in our facility when this project started. If you do a literature review, there's lots of studies out there that are showing that targeted education, especially the use of champions when you're initiating delirium bundles, such as the ABCDEF one, can be highly effective in improving the accuracy of delirium assessment. We could actually only identify 1 study that looked at the actual documentation of that assessment and how accurate the documentation was. Common barriers to using the CAM ICU just in general are a lack of knowledge of delirium by nursing staff, and then difficulty assessing our intubated and ventilated patients. So I've witnessed a lot of interventions over the past decade or so to try to decrease delirium in our patients, including the drastic reduction of benzodiazepine use in the unit. But about 2.5 years ago, there was a hospital-wide initiative with ICU for all of our ICUs in our hospital, where they decided to initiate the ABCDEF bundle and appoint delirium champions in each ICU on day shift and night shift, and really roll out this big push on education. This all happened very quickly and was pushed out very quickly. And so what happened was it felt a little chaotic and almost disorganized. So we had champions, they were pushing out the interventions, and there was a lot of education happening, but not on one aspect of the bundle at a time. It was just kind of on everything all at once. And so then we had Burn Center leadership over here going, okay, but what is our delirium rate? How are we going to know if what we're trying to do now is effective, and how are we going to know, how are we going to compare if we don't know what we're starting with? So we kind of took a step back from what the whole hospital was pushing everything forward, and we said, wait, let's stop for a second and look, because when our nurse educator really started focusing on this, we realized that a lot of the documentation of our CAM ICU scores were inadequate. What she was finding and how she figured this out was she would look at the patient's, say, GCS, and the nurse would have documented that they were following commands per the GCS. But then when she looked at the CAM ICU documentation, they would be assessing, or they would be documenting unable to assess on feature 2. Well, if your patient's following commands, you should be able to assess feature 2. The other thing that gave it away was fluctuating RASS scores were being documented throughout the shift or throughout the day. but the patient would be saying they were negative for feature 1 for fluctuating mental status. So those were the two kind of errors that caught her eye and why she started looking into this more deeply. So there's multiple phases to this project, but the actual intervention that we're going to look at today for the data that we're going to see is what she decided to do was send a tailored, customized feedback to each burn ICU RN that had documented an incorrect CAM-ICU score through email. So this was a customized email based on the patient's or the RN's documentation, and I'll talk to you a little bit more about that in a second. Our setting is a 12-bed BICU in a large academic verified regional burn center. We have 43 BICU nurses that were included in the study. We excluded float nurses. And then again, the intervention was an email that individualized corrective feedback. So the first kind of time period was that time period I was talking about when we were rolling out all this education. There were learning modules and huddles and one-on-one individualized education happening in the burn ICU related to delirium and the bundles. And then there's the pre-corrective feedback time period where after the hospital-wide push-out, when we kind of took a step back, we started actually auditing the accuracy of the charting, and that's when we realized that everything we had just done had not worked. And that was a random sampling. And then the post-corrective feedback period is the period of time after we initiated the emails to the BICU RNs. The pre-project period where we were rolling everything out spanned from March 2017 to June 1st, 2017, and all 43 BICU nurses participated. Again, it was modules, one-on-one competency training, and then small group huddles with CAM ICU FAQ handouts with our burn nurse educator. The pre-corrective feedback time period lasted from September 1st to December 31st of 2017. That's the period of time where we just kind of took a step back and started auditing to see where we were at. And then the post-corrective feedback time period took place from January to September of 2018. Every 2 weeks, every BICU RN who had documented a CAM ICU assessment was audited. And it was the first CAM ICU assessment of the shift, so the first CAM ICU assessment of day shift or night shift. Anyone with an inaccurate delirium documentation was sent an email with corrective feedback. It included a snapshot of their actual documentation and then an explanation of why, after the burn nurse educator looked through the chart and got a better idea of what was going on, why that was incorrect. And then when this project or when this intervention was rolled out, the burn ICU nurses were told that if they had greater than 3 inaccurate documentation audits, then she would start CCing the burn ICU nurse manager. So the measures, again, it was the first assessment of the shift, and what she simply looked at was the patient's motor assessment on the GCS, so were they following commands or not, the patient's RAS score at the time of the CAM ICU delirium assessment, and then accuracy was determined to be very simply correct or incorrect. And our burn center leadership set a goal of 90% documentation accuracy for this intervention. So here are the results. So the pre-corrective feedback time period, again, this is the time period after we did the big push out of education. You can see that we had rates of accuracy varying from 30%, the highest was 73%, but it was an average of 49% accuracy during that time period. The intervention started on January 1st of 2018, and interestingly, you can see we had rapid improvement just from the kind of threat of this tailored feedback, and that we were going to be auditing every burn ICU RN every 2 weeks, because we didn't start till January 1st, and you can see that very first assessment, we had 100% accuracy. So there are a couple dips down there, which I think can be, normal fluctuations. We didn't analyze nursing experience on this formally, but just anecdotally, there were even still experienced nurses occasionally making errors on their CAM ICU assessment. So it didn't seem to be just new nurses that slipped. Experienced nurses also occasionally slipped. So 0 to 5 months during the pre-correctional feedback period, 10 out of 16 months met our goal during the post-correctional feedback period. Our partners at UT Southwestern helped us analyze this data, and it was significant. And then this is just showing a little bit further into 2018, we continued to meet our goal of greater than 90%. So you can see we did show some pretty rapid improvement utilizing this intervention. She also did just to kind of tell you, she did a survey of the burn ICU nurses before this intervention started, just on their feelings about the CAM ICU. And notably, about 40% of them felt the CAM ICU was either not a valid tool or not accurate in assessing their patient's delirium, or that it was not user-friendly. And 76% of them thought they were documenting it accurately, when our data showed it was closer to 49%. So you can see there was a pretty large disconnect there. But I think that 40% not finding the tool valuable is also telling. You know, it's hard to convince people to do things a certain way if they don't buy into it and believe that it's valuable for their patient's care and assessment. And we feel like that was part of what was happening. Traditional ICU delirium education methods really didn't seem to work. The whole bundle, delirium champions, all of that stuff that we did, it wasn't working as far as improving the accuracy of our documentation. Using the very rigid guidelines like, hey, if you're documenting they follow commands on your GCS, then you should be able to assess feature 2. Just very clearly stating those guidelines seem to really help them understand how to better document. And then I'm sure we have all experienced this in our burn ICUs, but feature 2 can be particularly difficult to assess when you have patients with upper extremity burns who may be wearing splits or have limited mobility. It can be a little bit harder to document or to assess things like squeeze my hand. Our nurses were taught, if they were unable to squeeze hands, to think of something else where the patient could show that they are hearing you, such as stick out their tongue every time they hear an A. And then the other, kind of outcome from this is that the nurses were actually able to go back and review those emails. The emails, they had those emails now where they could easily assess them and think, okay, what was it she told me that I did wrong the other day? Let me go back and look and make sure I'm doing it right on this patient. So in conclusion, using corrective feedback did seem to improve the accuracy of our RN delirium documentation. Thank you very much. Questions?
Thank you very much to the Southern Medical Association for inviting us to come and present our work. We're going to be talking about wounds. The authors have nothing to disclose. Newsflash, in case you didn't know, burn care is the bread and butter of burn nursing, and it's labor intensive, resource intensive, all of those things. That's why we're here today, right? And competency is critical to ensuring we have optimal patient outcomes. We've talked a lot about that this meeting also. So in our burn center, and particularly the ICU, all new nurses to the burn center go through an evidence-based preceptorship program. We've branded it Tip Top. All of the tools are customizable to your area, and they're aligned with the Burn Association's BICU criteria, the Burn Nurse Competency Initiative. Now, despite this program that we've had in place for several years, our nursing staff was frustrated and identified some gaps in our wound care skill sustainment after that initial preceptorship. Some of the factors were inconsistency in the teaching and reinforcement of wound care techniques both during and after preceptorship. We lacked a formal skills sustainment program, and there was also a perceived decrease in our confidence in wound care. So that prompted us to start a process improvement project with our goals being reestablishing confidence in wound care, developing and implementing a skills sustainment program, and to improve the quality of our burn care delivered in the ICU. So we branded it WIP, Wound Improvement Project. I will let you take the inference there. So the team was formed in the spring of 2018 and continues to meet monthly. It consists of competent and proficient bedside nurses that on Benner's Novice to Expert scale, and the burn ICU manager and myself, the clinical nurse specialist, serve as mentors for the team. It's still very much an ongoing project. Our interventions include quarterly educational events. We're going to highlight that during our staff development days, and peer-to-peer evaluation of staff actually during wound care. And our measures included a confidence survey and evaluation tools that were objective, and wound care documentation audits. So lots of education has been provided with several different modalities throughout this project, but I wanted to highlight a couple of things we did in particular for our staff development days that we try to do quarterly. So the picture on the right is a burn admission scenario that everybody went through. It was a 2-hour scenario. So they did a large burn. They had to do all of the wound care, face mask, the shower, do the pictures, resuscitation. We also included all of the Joint Commission requirements, such as restraints. And then it turned into a post-operative patient where they had a bleeding event that they had to manage. So that also included the use of the Belmont. Then our second big intervention was wound care wars. And what we did was pitted teams against each other. And they had to actually perform wound care on each other. So it was one of the staff members was the patient. The dressing had to be put on properly, had to follow the orders. It had to be done, with infection control in mind. As you see, everybody is dressed up in the garb there. And it had to be functional. So we actually had our rehab staff, our physician assistants, some independent people come in and then assess the dressing after. So if the patient got up, they actually had them do squats. They had to walk. So if the dressing fell off, well, they didn't get a point for that. And we had to, of course, put the socks on when they were walking. I dinged them for that if they didn't think about safety. So the feedback for all of these interventions, as you can imagine, was very positive. People liked simulation. And so we were really encouraged with this, and we really try to do something like this with every staff development day. So our skill sustainment program, again, is still very much ongoing. We've had a lot of growing pains with it, and it's changed along the way. But currently, all BICU staff are assigned 3 sessions with a WIP member, and this really is a day shift where they participate in wound care along with that WIP team member, and they're able to provide real-time peer-to-peer feedback and coaching. Hey, maybe we need to do the dressing a little bit differently this way. We have developed some evaluation tools, again, based on the BINC criteria that included, this tool is just a little snapshot. We used 4 out of the 7 competency statements from the wound management domain from BINC, and this is the WIP member filling this out and evaluating the staff member. And as you can see, it's on a 0 to 10 scale. The tool also included a self-evaluation for the staff member. They completed this before their WIP sessions began and after they were completed, also on a 0 to 10. So as far as our measures, we developed a confidence survey, and it was a 10-item anonymous survey about just several things we thought we were having issues with on the unit at the time. And as you can see from the top, we did capture the number of years of experience in the BICU, which will become important. And finally, we looked at our wound documentation. This was a tool developed several years ago for a previous PI project. Basically, you get a point for every section that's filled out correctly and completely in our EHR. So the more wounds you had, the more possible points you had. And so it was really just a factor of how many points you got based on the total. And when I say completeness, like if you just put burn on the right arm, you didn't get a point. I wanted to be seeing, is it weepy, is it blanchable, is it non-blanching, and sensate, et cetera. So as far as the results, this is a little bit of a busy slide, so I'll walk you through it. So our baseline confidence survey was given during the first staff development day back in the spring of 2018. And we measured time points comparing baseline to then our second and then our third time point. And as you can see, baseline to the first time point in January, nearly all of the items were significantly improved. But when you look from baseline compared to the third time point, you see we lose significance on several, and we really only ended up with 3 being significant. So we looked at this, like, why did it actually go down? Well, our second time point, we did miss half of the group, so we only had 33 respondents in January. But when I looked at experience, at our baseline, 58%, so almost 60% of our nursing staff had 3 or fewer years of burn ICU experience. And that did even out at the next 2 time points to 40%. So you would expect with an increase in experience, you would have an increase in confidence. So I'm not sure if we were really measuring our interventions or just the fact that we were providing more education and people had more experience. As far as skill performance, WIP members have evaluated 24 BICU staff so far over 72 sessions. 40 are still pending completion, and this has taken a year, and we've only gotten a third of the staff, so it is a little tough to do this. We've shown a positive trend in the actual performance that was measured by the WIP member, but it has not shown to be statistically significant at this point. However, we really feel the best result of this is we've demonstrated how to actively perform evaluation of the group by the group, if you know what I mean, that peer-to-peer. And as we can see, self-evaluations, so again, this is the staff member going through the WIP sessions before and after. All of the items showed significant improvement in how they felt they were doing and how confident they were. And finally, our wound documentation, as you can see, there's several dips along the way from this year of data, but really from our baseline back in April, we were at about 80% of wound documentation completeness and closer to 100% kind of consistently the last few months last spring, or this past spring in 2019. So in discussion, wound care confidence and documentation have improved since the initiation of our WIP program, and staff feedback has been very positive. They love the simulation and the one-on-one, and have really found the program to be helpful. A lot of positive comments. And again, we've incorporated the practice of peer-to-peer feedback into our bedside nursing practice on a daily basis. So several limitations. We're very aware that there's a potential bias of evaluating. When you evaluate, things tend to improve. And our tools have undergone several revisions throughout, making data analysis pretty challenging. This is, like I said, resource intensive. It's either feast or famine in our burn centers, right? And we have competing priorities, things that are coming down from, management. But we found it was really important to try to sustain this. So in our way ahead, we want to rotate new members onto the team and members that have been there for a while off on some kind of a schedule basis that we haven't determined yet. And it would be great if we could incorporate these sessions into an annual competency evaluation, but as we've only had a third of the staff go through in a year, we've got to figure that out a little bit. And expanding the program somehow to the entire burn center, knowing that we have to customize that to the different areas. And again, just continuing to progress and sustain and evaluate that peer-to-peer practice. So in conclusion, wound care skill development, it really has to be fostered after preceptorship. It's not just that they get there at 6 to 8 weeks and then they're done. And development and evaluation of some nurse-led or team-led sustainment programs are needed, and the ABA BICU criteria, the perfect framework, they're already set up to be able to do that. Because we all really need to be thinking about progression toward proficient and expert practice, right? And finally, our team worked so hard. This was very nurse-driven. This was grassroots. I was the mentor. I didn't do the work. They did the bedside work. They came up with the idea. So kudos to them. They're all elusive. I couldn't get all of them, but you can see they're having fun here. And I really want to thank you very much, and I'll entertain any questions.
Good morning. I'm Amber Thompson from Chapel Hill.
And I'm Raina Gorsick. I'm the clinical nurse leader. We have no disclosures to report. So a little background about our medical center. So it's a level 1 trauma center. There's a 803-bed facility. We have 36 beds in our burn center. 21 of them are ICU capable, and we do take all levels of care, including pediatrics and adults. So in May of 2017, the fiscal year, we had a huge increase of central line infections. So we had 18. So we sought out to fix this. This was a very high number for our unit. So a background of, we were already doing surveillance rounding, and a common thing that we found was that our standard of care dressing wasn't staying in place, but it was kind of always that way, but we would just replace it. So we found that we couldn't use an occlusive dressing over a burn tissue that had a central line or an dialysis catheter. Our hospital nursing policy stated that we were supposed to use a betadine soaked gauze, just soaked it on a 4x4 dressing and just lay it over the central line site. And the other thing that we found is that the CHG disc that we were using was not indicated for burns, and that was also the standard of care to be used for central lines. Some other things that we found was that there were a lot of variations in nursing practice. So nurses thought that the betadine were supposed to be wet, and then they thought it was supposed to be dry, and then we were like, well, what are we supposed to be doing? We were really challenged with trying to keep the 4x4 in place. If it was over the neck, over the chest, sometimes we would try to use stretch net, but really trying to keep that in place. And some nurses were changing it every 2 hours or every 4 hours, or they didn't know how often to change it. It was unclear if we should be cleansing the site, so if the betadine dressing fell off, they would just reapply it, and we didn't know if we should be cleansing it. And the nursing policy also stated that the dressing should be changed every 48 hours, and that was not staying in place for 2 days. So what we sought out to do is to try to find a dressing that would become occlusive over that central line or over the dialysis catheter that we could use through burn tissue. We also wanted to find a type of dressing that would stay adherent, so we wouldn't have to change it frequently. And we also wanted to decrease the central line infection rate from 18 over that year. So we formed an interdisciplinary team, and we did a literature review, and we couldn't find any literature to support what dressing we should be using over the central line through burn tissue. So we queried other burn centers, we sent out surveys asking what their standard of care dressing that they used, and we found a lot of variation in the standard of care as well. So we sought out some reps and just asking, this is our problem. Do you have anything that we think that we could use for this? So we trialed 9 different types of dressings, and we really got creative in our artistic ability, trying to maybe if we put it this way or if we use that. So we tried a lot of different things to what can we put over that central line so it'll stay in place. And the first dressing that we found was actually the silver oxysalts dressing. This was the first potential one that we're like, oh, I think this might work. It's actually staying in place. So we set up a trial to use this over a 3-month period, and the dressings were changed every 3 days, along with our standard of care central line practice that we changed new sticks every 6 days and change over wires every 3 days. And then we also, if there was a mixture of burn and intact skin and it looks like it wasn't adhering, we would actually moisten that with sterile normal saline to keep that in place.
We really wanted to get rich and come up with our own, dressing, but we were really creative. It didn't happen. Anyway, but the results were pretty astounding for us. During the 3-month trial, we did not have any central line infections, but we continued to go ahead and, because of that, we continued to our surveillance, and we noticed that nurses were really positive with the fact that it stayed on, and they weren't having to figure out what do we do and how often do we need to change it. So because of the success of the 3-month trial, we continued everything that we were doing, and I'll talk about that in a second. So our CLABSI rate decreased. So fiscal year 2017, it was 10.38 per 1,000 line days. And then in fiscal year 2018, we went down to 3.01 per 1,000 central line days. So we had 6 central line infections, which was a 73% reduction from 2017. September 20th, 2018, our hospital recognized the burn center. I don't know about you guys, but we don't get a lot of recognition in the hospital. So we were really excited to get like pizza and cake and stuff for going 145 days without eclampsia. And then this really caused the hospital to say, like, if the burn center can, decrease their eclampsia rate with no skin, then surely you guys everywhere else can do the same. So it did lead to an update in our hospital-wide policy because the policy was written before. I'm sure you guys run into the same thing, thinking of the majority of the patients in the hospital. So it's all a good idea, but if our patients don't have the skin and all of that, it doesn't really always apply to us. So now central line maintenance policy includes this dressing, and they just added the word denuded because we started seeing that other units were calling us and saying, hey, what's that dressing you're using? Can you tube us some of those because our patient, we can't get the dressing to stick. So a total of 51 patients have used this silver oxysalts dressing within the fiscal year 17 to 18, with only 6 of them obtaining a central line infection. And some patients had this dressing in place for over a year and never developed eclampsia. So some things that not just our infectious disease nurse was really adamant that we made sure we conveyed, that it wasn't just the dressing, but that, we did education around how to apply it, how to keep it on, and then we did multimodal interventions such as surveillance from our ID nurse, our quality improvement folks in the hospital, and we did these audits. Yeah, we should know that word, right? Our audits constantly, but we would do them at different times. Nurses love that, and we would come in the middle of the night, daytime, all those fun things. And that included the lines being labeled properly, so no expired lines for the audit to be accurate, and then proper documentation of central line care, because that was also something that we audited. We still continue all this, but the first line of defense is, do we even need a line? Can we get some peripheral IVs? Are you sure you still need a central line? And it's now the standard for central lines placed through burn or denuded tissue hospital-wide. It's still changed every 3 days over our hemodialysis catheters or central lines. And we still do surveillance weekly, and our infectious disease nurse also pops in and does surveillance rounds of our lines as well. Any questions?
Good morning, my name is Stephanie Townsend, and I'm a care partner at the Evans-Haynes Burn Center in Richmond, Virginia. I have no disclosures for this presentation. Care partners come in various forms, including certified nursing students, certified nursing assistants, as well as nursing students. We serve as assistants in all areas of patient care. In addition to the general responsibilities assigned to care partners within BICU Health, burn care partners are specifically trained on the various dressings used on our patients. We, aside of RNs, have been taught to recognize, advocate, and escalate care for patients when there are signs of infections, changes in their wounds, and changes in the patient as a whole. Care partners are often the voice behind referrals to dog therapy, music therapy, art therapy, our trauma psychologist, and our volunteer who is a burn survivor. We are the leaders in reducing waste on the burn unit as we have pioneered multiple solutions to ensure that our special supply wound care products are being properly charged for, as well as being dedicated to checking patients' rooms before we bring in multiple or additional supplies for their daily wound care. Moreover, we are responsible for monitoring patients who are stepped down in general, their vital signs, patients who return from the OR with post-op vital signs, as well as post-sedation vital signs. Through the completion of said tasks and the transparency of roles between care partner and RN, we have capitalized on the expectations set for us and gained the trust of the multidisciplinary team. Through trial and error during my time on the burn unit, I have learned that care partners have a voice within our team. We have brought our concerns to nurses as well as providers, physical therapists, occupational therapists, dietitians, and our trauma psychologists, and helped to be a part of significant changes made within patients' plan of care. I've taken this a step further in my care partner role and performed additional tasks on our unit to aid in the cohesiveness of our unit, to boost morale, and to bridge gaps in communication. In doing this, I believe that I have set a standard for our other care partners to follow. With the role of preceptor to 10 new hire care partners on our unit, I feel like our current burn care partners have expanded the job roles and responsibilities, as well as exceed expectations when it comes to our job description. In recognizing this, we saw an opportunity and decided to do research. I believe that burn care partners are an essential part of our team, as we have roles in all aspects of patient care. Traditionally, burn care partners are only thought of as being only part of wound care. This is manifested by the university chief objective description, which states, to provide direct age-specific care to a patient or group of patients based on medical orders and the plan of care under the direction of an RN or licensed independent practitioner. But in reality, burn care partners do so much more, including improving patient satisfaction, optimizing wound evaluation, cost containment, reinforcing patient education, and identifying early signs of infection. The aim of this study was to explore the role of the burn care partner and how they function within the multidisciplinary team. A PubMed search of the literature using various keywords related to the term care partner found only 245 articles, of which only 4 were pertinent to our study. Our initial literature review showed several trends of the role of the care partner. The first was that care partners are linked to a safety culture with possible reduction of restraint use. The second was that care partners may be helpful in reduction of turnover, and the last trend shows a lack of the inclusion of the care partner within the burn discussions. I developed 2 10-question surveys using SurveyMonkey and administered it to our burn center staff, with one being specific to burn care partners. These surveys were intended to see whether or not care partners felt like they were a part of the multidisciplinary team, as well as whether or not the team felt like care partners were pertinent teammates. As you can see here, 50% from both the care partner and the multidisciplinary team results show that feelings of care partners always being felt as well as viewed as an integrated part of our team. Here we see that 50% of care partners who always feel that their presence makes a difference in patient care, whereas the team's results show that 84 feel that care partners play a vital role within patients' care. This is showing us that the multidisciplinary team is rating the care partners higher than the care partners are rating themselves. Here we see a bit of a draw in the care partners' results with a 30% result for sometimes, usually, and always when asked whether or not care partners feel like they have a patient or a say in patients' care. Interestingly, though, you can see that 47% of the team responded that they always include care partners in their patient's plan of care that the care partner is assigned to. Again, the team rates the care partners higher than the care partners are rating themselves. These 3 questions were the most statistically relevant to my survey. With the responses from the team, I found that the majority do trust their care partners when they come to them with concerns regarding their patients. The majority always relies on care partners to advocate for patients' concerns to them, and they believe that care partners are involved in patient care a great deal. Interestingly, I found areas of improvement, including a small percent that only sometimes trust their care partner regarding concerns that they bring to them about their patients, who also rarely rely on care partners to advocate patient concerns to them, and who believe that care partners are only a little involved in patient care. With the responses from the care partners, I found that the majority of them feel that the care that they give does make a difference in their patients' outcomes, and the majority felt trusted by their coworkers. For areas of improvement, I found that only 10% of care partners feel comfortable approaching physicians about concerns and or questions about their patients, with 20% that never feel comfortable in doing this. Also, 10% of care partners' results stated that they rarely feel like the care that they give makes a difference in patient outcomes. Overall, limitations regarding the study include a small sample size. This was sent out to 57 team members of our multidisciplinary team with only 19 responses and 15 care partners with 10 responses. Additionally, this is my first attempt at designing a survey, therefore the two versions were not comparable for each question. Burn teams pride themselves on inclusion. Going forward, I would like to see more research in this area as well as article publications. Saying that, I would also like to see this as an opportunity for those present to initiate my survey to your units and send me your results. Together, we can see how included our team members feel. And here are our references that we found. And with that, I'll take any questions.
Good morning. I'm the burn program manager for Parkland Regional Burn Center in Dallas. And I have no disclosures. This presentation is really to give you some inspiration on some things we've been doing with our survivor support program. A little background, we're a large regional burn center. We're the only verified burn center in the northeast part of Texas, and you can see from this map, this was a kind of a snapshot in a 5-year period of all of the counties in Texas that we drew patients from. In 1 year, we drew patients from 96 surrounding counties, so we have a really large geographic catchment area. We are verified as an adult and a pediatric burn center. We have 12 burn ICU beds, 18 burn acute care beds, and we see between 750 and 850 new burn admissions annually. In early 2017, I turned my attention to our burn survivor support, our burn aftercare program, to see areas that I could strengthen this program. To kind of tell you where we were at that time, we had multiple survivor support resources in place. They just kind of lived and existed in different areas of the hospital. So by my team, the burn program team, we coordinated the adult burn survivor retreat, which had been in place since 2010. Which was a weekend getaway for a burn survivor and a spouse or support person. And then we also held an annual burn survivor and staff reunion party every year in the spring. Coordinated by our partners at the medical school and the physical medicine and rehabilitation department, UT Southwestern, they had coordinated the monthly support group for greater than 15 years probably at this period of time. So support group had been around for a while, it just wasn't coordinated by the actual burn center. And they also coordinated our Phoenix SOAR peer support program, which at this point in early 2017 had really fizzled out. And speaking with the Phoenix Society and other SOAR coordinators, I realized that this is kind of normal. A lot of centers go through fluctuations in their peer support program engagement and activity. Around 2010, 2011, our hospital actually went through a period of governmental oversight where the volunteer services department really clamped down on who could be in the units and the requirements they had to go through to become a Parkland volunteer. And I think this really squashed our peer support program for the few years that followed. So when I was looking at this, I'm like, okay, we have to fix SOAR too. And then we had our pediatric burn camp, which has been going since 1992, so many years of our pediatric burn camp, very successful, that's still coordinated by the founder of that camp, our Parkland outpatient rehabilitation manager. So you can see we had a lot in place. Everything was just kind of siloed. We weren't all collaborating. Around that time, I had recently spent the whole week at our pediatric burn camp the summer before, and I was very inspired by our adult burn survivors who were coming as counselors and how much fun they were having at camp. So I coordinated our own adult burn survivor day at camp. We found a local camp that was willing to work with us. They did kids camps during the summer, but during the year they focused on adult team building corporate type events. And I I went with them and asked them how they would feel about working with me to accommodate our burn survivors and their families, and they were very helpful. So this was all happening around the same time. We had this event. We had a very core group of probably 16 to 20 people that were always coming to our reunion, that always came to the retreat, that always came to support group, and these were the people that I was able to reach for this event. They had so much fun. You can see one of our patients there had a brand new prosthetic leg, and he was ziplining, he was climbing 40-foot walls, and I was running around behind him also between it and, oh my gosh, be careful, be safe, please. But it was just a really magical day, and so that had inspired me to start thinking outside of the box of what we could do for burn survivor events in general. So I was thinking about, okay, when I had this camp event, I could only really reach that core group of patients that we already had communication with and I had emails for, but there was no formal way to communicate with patients who were in the hospital so that they could know about our aftercare activities. And then after discharge, I really had no way of communicating with the patients once they left about events that we were doing. I wanted to re-energize attendance at these events. Like I said, it was a core group of people who were very dedicated, and I was hoping, I was thinking about how could we get some new attendance, new people to attend, and then how can we restart our peer support program. So I started to think maybe we need to create some kind of umbrella program that really pulls all of these elements that we already have in place together into one kind of comprehensive program where we all collaborate together. So I started talking about this, engaging my colleagues at UT Southwestern who were running support group, with the outpatient rehab manager who was running our pediatric burn camp. She actually came to the adult camp day and assisted with some of our patients who had physical challenges, figuring out what they could and couldn't do. So I had already kind of hooked her into the adult side as well. And we actually all got together, we met, we talked about what currently was in place, which populations did it target, did we have enough stuff for pediatric, for adult, where were the gaps? And then we brainstormed ways to collaborate more formally, especially for SOAR, support group, and those kinds of things. So we came up with a few goals. One was we wanted to formalize the introduction of survivor support resources for our patients and families so that patients who were going home knew that these things existed before they ever went home. We wanted to provide more opportunities for informal peer support. I've found just anecdotally that many survivors and families are not thrilled about the idea of going to a support group, but if you get them to one of these social events, then that informal peer support, that magic that happens when you get burn survivors and their families together occurs in these informal settings. And then I really wanted to name this program so that our community, our survivor community, had a sense of belonging, and then it appeared to be we were all one cohesive program working together. So through a lot of scribbled sticky notes and time thinking in the car on my commute and Googling, we came up with the acronym RISE, which stands for Resources, Inspiration, Support, and Experiences. And we actually approached our marketing department at our hospital and said, hey, we're creating this new program. We're going to call it RISE. Can you help me create a logo so that we can brand all of our event flyers and support group, and so that everyone knows that we're all working together for this program? So they were very helpful. They created this, threw the little arrow in, which I loved, and they created this flyer for us, which describes all the elements of the program, all the resources that we have in place for survivors, provides our contact information. I failed to say that our burn survivor aftercare program, while it's primarily my responsibility, we have 2 burn nurse clinicians on our burn program team that while their primary focus is our quality improvement program, they were also very engaged and eager to help with burn survivor support, so they really stepped up to assist me with this program. And then we created a form for patients to join RISE, which is really just giving us permission to email them. We asked for their mailing address and their email, and then we also asked for who their spouse, support person, or parent's name is. And then we actually have figured out that we needed to include the spouse, parent, or support person's email as well. Oftentimes they wanted to join and get the communications as well. So we created these documents, and then we started thinking about, okay, what what other resources would we want to provide in a more formal way. We identified the burn model system fact sheets. We have Phoenix Society brochures, our burn survivor support group brochure, and then any upcoming event flyers that we had, we kind of collected and said, okay, these are the kind of packet of resources that we want patients to go home with. And so we started calling those our RISE packets. And then we needed to figure out how to get the packets to the patient and explain to them about the resources. So we created the concept of RISE visits. And I was at this meeting last year and had a poster that went into more detail about how we identified patients for RISE visits and captured them and followed them and what our results were as far as actual RISE visits. So for brevity, I'll just explain that we targeted patients with greater than 15% total body surface area as kind of automatic RISE candidates. But we also educated the staff that they could refer anyone for a RISE visit that they thought would be a good candidate for survivor support. We followed the patients during their hospitalization for the ideal time for a visit, which is somewhere when they're getting closer to going home, but not the day of discharge, so that they can better absorb the information. And then the bedside visits are performed by either myself or one of our 2 burn nurse clinicians. The visits typically last 20 to 40 minutes, and we found it's very helpful to have family or their support person present. When we go in for a visit, we basically just introduce the idea of burn survivor community. Like, hey, we know you're about to go home. We actually start the conversation usually by saying something like, sometimes when burn survivors and their family members go home, they can start feeling a little isolated and like other people don't understand what they're going through. We have found that it's helpful to be around other burn survivors and family members who may have gone through something similar. And the way we help you find those people is through this RISE program. So we kind of introduce the concept. We review all the materials in the packet. We talk about whatever upcoming event is coming up, like, hey, we really hope we see you here. This is what we're doing next. We usually end up answering some kind of questions about going home that come up during the visit. And then we also do a very basic introduction of social skills based on the Phoenix Society's Tools for Thriving document that they have on their website. We start the conversation by saying, have you thought about what it's going to be like to go back out in public with your burn dressings or visible scarring? And I think all of us have been surprised by the reactions to that question. Many, many patients and families are eager and willing to talk about that, and a lot of them have been sitting there thinking about it. Of course, we get the occasional patient that's like, no, I'm fine. If anybody says anything, I'll punch them in the face, which was an actual response. But a lot of people will say, yeah, I actually have been thinking about that. And so that opens us up the door for us to start talking about how to deal with questions from strangers and staring. And I think all of us will tell you that out of all of this, leaving patients with just that little tidbit of information before they go home, with just thinking about ways they can cope and kind of opening that conversation is what feels the best to us. Regardless of what other outcomes we see from this, I think that social skills training has just been very rewarding. And then if they're pediatric patients, we discuss school reentry, or if they haven't had peer support at that point, we offer it, but a lot of times they've already had it. So in the first couple of years, again, I'm not really presenting the data on this, but we've done over 100 RISE visits. We now have a robust email communication list because when we do the RISE visit, we offer them to sign up with using that form, and so we've collected a really long list of patients that we communicate with at least monthly. We now have committed to free quarterly social events for burn survivors and their family members. I'll show you some pictures of some things we've done in just a minute. We still do monthly support group, but we've now added guest speakers. So the hour prior to support group, we bring in a guest speaker to talk about some kind of topic. We've done everything from keep setting and maintaining goals, like as a New Year's resolution thing last year. We've done itching. We've done a session on the laser therapy that our surgeon came and talked. So it's been interesting, and I think we've increased support group attendance doing that. We still have our burn survivor retreat. We still do our outdoor challenge days, now what we call that adult camp day. Our peer support program is up and running again, and although the number of peer supporters we have is small, they are very active, and we are currently growing that. We tried to initiate a preschool camp this year. It failed. we had to cancel it due to low enrollment, so we're going to approach that with a new look next year and try again. So some of the things we've done, we did an ice cream social at a butterfly garden in Dallas, where we kind of rented out a room. We brought tons of ice cream. Our staff came and served, and the rental of that room included free admission to the butterfly garden for our burn survivors and their families. It was a lot of fun. We sponsored, we were lucky enough to have Phoenix World Burn Congress visit Dallas, and we sent 40 of our burn survivors and family members to that while we were in Dallas. And this was right when RISE was starting, so we created RISE t-shirts. Again, just to create that sense of community. We gave them to our survivors. We did an order for staff, and we got the Phoenix Society's permission to put the Phoenix SOAR logo on the sleeve for our peer supporters. So they got special shirts if you were a trained peer supporter that had the Phoenix Society logo on it. We now do a family fun day at that same camp where families and kids of all ages can come. We just did this recently in September. We had around 85 people show up. And you can see this is one of our patients with double arm amputation who jumped off a tower. Again, my heart was racing, but he came down smiling, so. And here he is as they're setting him up to ride on a giant swing as well. We did, so those things clearly cost money, right? But I wanted to show you a couple of things that we've done that have been successful that didn't cost much money. We've actually had parties right at the hospital in the room that we have support group in. We do a Burn Awareness Week party that's Valentine's themed, since Burn Awareness Week is in February. It's a We Love Burn Survivors party. We just have coffee and pastries. It's like a networking thing where we explain resources that we have, and we talk about the upcoming year, and we also try to get patients and patients' families from the unit to come down and meet our burn survivor group. And we also usually we did one where we did many sessions, like we did a little 15-minute sessions on positive self-talk, like 3 sessions throughout the event so that people had another reason to come and learn something. Unexpected outcomes from just kind of saying, okay, we're RISE now, we're all working together, is that our physician and clinic staff actually refer us patients all the time. The patients that have not been inpatient for many years, sometimes even decades. I'll get a call and say, hey, this patient was burned in 1995, but they're now here looking at getting this done. I think they'd be a great candidate for RISE. So we've connected with patients, from many, many years ago because of this. And then actually about 6 months after we started this whole initiative, our partners at UT Southwestern said, hey, y'all are doing such a great job with this. Would you like to move the coordination of support group and peer support program under your team so that it's all under RISE together? And so we did that. So now our team does coordinate support group and the peer support program too, and I think that's been really amazing to connect patients from the inpatient side to the outpatient support group. Continuing challenges, it is very hard to catch patients and get just that right timing for visiting and explaining about resources. When I analyzed the data for our first year, we had about a 9% miss rate for candidates that we had flagged that we wanted to visit, and we're still working on that. Our geography of our catchment area is so challenging. I can attest to the personal heartbreak I feel when I meet with a patient for a RISE visit who has been coming to support group while they're inpatient, and I talk about an event that we have coming up, and they say, oh, I would love to come, but I don't have any transportation. I don't know how I'm gonna get there. I don't have anybody that can take me, or they live 2.5 hours away, so it's hard. And then when I came into this role, I had 8 years experience as a burn ICU nurse, an educator, and 0 years experience in party planning. So I think the hardest thing for me personally has just been figuring out, how do I find event locations that work for us? How do I get contracts through our legal department? We're a county hospital, so that in itself is an ordeal. How do I get invitations out, and how do I advertise this to people? I figured out pretty quickly I wanted to pay just a set fee, not per person fee, because 100 people might RSVP, but then only 60 show up. So I look for places now that, I just pay one set fee, and we say it's going to be between 75 and 100 people or something like that. But I've learned a lot of lessons along the way in party planning. Fortunately, we are very well supported by our Parkland Foundation, which is the nonprofit that raises money for our hospital. So we have, all of this programming is supported by donations, and we have that support, so that's good. So that hasn't really been the problem. It's been the other aspects of resources, time, really. Questions?
Good morning. David Rogie from Indianapolis. Which way? Perfect. So I have no disclosures. From the Richard and Firm Experience Center, just a little bit of our center. 15 acuity adaptable rooms. We actually have 13 clinic rooms now. We changed some stuff around. 2 dedicated operating rooms, all within in the center. 2 pre-post-op bays. We have overnight family rooms, a medical spa, dedicated therapy gym, and about 5 hydrotherapy bays. So the nice thing is our center is all included on the 4th floor of our hospital. So we're kind of fortunate that it's a one-stop shop for our patients. So we're talking about donor sites today. I think, as we all know, they aren't necessary for deep, partial, and full-thickness burn wound closure or coverage. Usually take about 10 to 14 days to heal. They vary in size depending on your TBSA. They can be very painful, and in our experience, they may delay your discharge and increase your length of stay. Length of stay in burn patients is described in literature as 1 to 1.57 days per percent TBSA. Factors that may prolong length of stay include third-degree burn, substance abuse, pre-existing comorbidities, inhalation injury, psychosocial circumstances, and in our experience, delayed donor site healing. So in July of last year, Dr. Sood came to me and said he wanted to try to start taking donor sites early in patients that were going to go on a 2-stage procedure. He wanted to harvest at the time of when we were actually primary debriding and laying homograft, bank the skin, and then use it at a later date. So basically the process works. Our staff physicians, either Dr. Sood or Dr. Hartman, will evaluate the patient overall. Looking at their wounds, we determine age, is nutrition heading in the right direction. If that all is good, they'll harvest the donor sites on the primary debridement. The skin is then meshed to the desired ratio that they determine in the OR, and it's stirred per our protocol until the 2nd stage surgery, and that can not be any longer than 10 days from the donor site harvest. So basically, I had to develop a protocol on how we were actually going to store the skin. I found the ARN evidence-based guideline implementation on autologous tissue management, and it kind of worked really well. So it gave great guidelines. So I developed a protocol that addressed the following: handling. All handling of the skin is aseptic, sterile technique. We package it in RPMI medium. Labeling is of the utmost importance. Patient identifiers, date of harvest, surgeon name, location of the donor site, what we rinsed it in. Storage, we actually stored it in our biological refrigerator in our clean core in the OR. It's just 32 to 50 degrees. The RPMI is changed every 72 hours. That's great because we have a dedicated OR team, and they're very diligent about that. And if after 10 days, if we haven't used it or we no longer need it, we discard it per our hospital protocol. So is there any benefit to doing this? So I did a retrospective review, identified our patients that basically we harvested that sustained just cutaneous injuries without any inhalation injury or major complications following surgery. All of them underwent one homograph procedure. We harvested donor site at that time, and then we placed the autograft at a later date. This is Group A. These patients were then matched with patients of similar age and as close as possible to TBSA. Again, with just a cutaneous injury, no other complications pre-surgery, and with minimal complications following. So I looked at their average TBSA, comparing those, total length of stay, and length of stay in terms of number of days. So Group A, that's our folks that we harvested donor site early, actually had a larger TBSA than our Group B. The length of stay in that group was actually shorter. And if we look at length of stay and number of days per TBSA, 0.96 to 1.6. None of these findings were statistically significant, but we do feel that they are clinically and financially significant, especially when you look at the average savings between the two groups. With Group 8 leaving a few days earlier, we actually save about $23,000. That's either for the patient or for our institution, depending on reimbursement. So in conclusion, I think we've shown that we can perform this procedure safely and effectively. We have decreased the length of stay, and there's a potential financial savings to the patient or the institution. And I'll take any questions at this time.
Okay, the last presentation for this morning's session is cerium nitrate containing electrospun dressing for mitigating infection and burn severity by Cortez Williams from right here, the ISR in San Antonio.
All right, thank you to the organizers for allowing us to present today, and thank you all for being here. I'm gonna try to go fast so that we can all get home, because I know I wanna go home and I know you all do too. So we actually have quite a lot of disclosures, but basically it all boils down to I'm up here giving my opinions and no one else's, and also all the work we've done, we went through the proper channels and we had all the proper approvals. So this presentation is going to be a lot different than most of the ones you've heard today. We're going to actually be talking about new dressing fabrication. So how can we make new dressings to treat burns? But not only just burns, our main objective is to make a platform technology that we can apply to all different types of prolonged field care injuries. So if you can imagine, we have a serviceman or woman, they're out there in the field, they can't get access to the proper medical attention. So can we give them a dressing that they don't need to be trained to use? We give them basically a regular ACE bandage, they put it on, it turns into a hydrogel, completely coats the wound area, protects it from infection, and it jumpstarts the healing process. And that's basically what we're doing. So I'll be talking a little bit about our preliminary results and how that's going and some of the methods that you can use to actually protect your drug or your bioactive molecules in this process. So again, we're trying to make an ACE bandage, basically, something that our service members are used to seeing. And we use that, do that by electrospinning. So electrospinning, basically, you're going to make a cotton-like scaffold. So just like your shirt or anything like that, that's kind of what it's really gonna feel like. And these are actually a little special because they're on the nanoscale. So all the fibers you make are extremely, extremely small. And because they're small, that means you have a lot of surface area, you have a lot of porosity, that means that it's breathable, and that means that you can actually have a lot of contact to the wound area, meaning your released drugs can release faster than some of the other methods, such as like spun bonding per se. So I'm gonna go a little bit into how this works. Again, this is mainly gonna be a lot front heavy on the fabrication and how we can do it and the tools that we have at our disposal to encapsulate and protect our drugs. So this is kind of a normal electrospinning process. Okay, so you're going to have a grounded mandrel, which is the silver piece in the middle. You're going to have your polymers that are going to be in some type of solvent, and those are going to have an electric charge. And that electric charge is basically going to propel a small, thin fiber onto your mandrel. And that's basically how you get a non-woven fiber mesh, or something like your shirt. That's basically what it looks like. Normally this is done in this method when you have polymer systems. But for us, we're trying to spin cerium-3 nitrate. So cerium-3 nitrate is usually used in conjunction with silver sulfadiazine, your normal SSD cream, to basically help mitigate some of the effects of the burn eschar. And again, in a prolonged field care environment, you're not going to be doing any debridement. That's not going to be something that can happen, so that you really want to stabilize that area so you don't kind of leach toxic metabolites out into the surrounding areas. So what we're actually doing is we're going to talk about two different methods. One is the traditional methods that most people use. They're going to mix everything together, and then they're going to try to make their dressing. Okay, so if you can imagine, you're mixing a drug in, and it's going to be exposed to the elements. Okay? The method that we actually are hypothesizing is better is using coaxial spinning. Now, usually coaxial spinning is also going to be using two different polymer systems, but what we have done is actually change this into an encapsulation method. So a lot of people have heard a lot about microspheres or nanospheres, nanoparticles. Basically what those do is you encapsulate a drug and you protect it from the elements. It can last longer, it retains its bioactivity. What we're doing is actually keep our drugs inside of our nanofibers. So that's like you have a shirt, and the fiber of your shirt contains molecules that can help heal you if you were to be hurt. That's basically the process of what we're doing. So I'll go through a little bit of our results. It's just going to be some of the results from the fabrication. How do we know that it's there, that it's doing what it's supposed to be doing? Are we actually protecting the serum from the elements? And then we're going to go into some of our in vitro studies and our ex vivo studies. We have done quite a bit of work on this. We actually just completed our in vivo studies, and we had great results, and we're going to move forward with the next area on that. But we're just going to focus in the in-lab portion today. So our results are actually, they're going to be a little backwards than you may see in like a research paper, and that's because we're trying to illustrate the encapsulation method of the coaxial spinning that we're actually doing. So our middle spectra is actually going to be the mixed up components. We take our drug, we mix it in with our polymers, and then we make our dressing. Okay? The first spectra is going to be that coaxial method, the encapsulation method, and then the bottom is going to be just plain polymer. There's no drug in it. And if you notice, the first and the third spectra are identical. Okay, that second spectra, you're going to have multiple peaks on the left side, and then also on the bump out, you're going to have another peak. This is kind of the reason why we chose cerium to do our proof of concept. Cerium 3 nitrate is absolutely terrible for electrospinning. It should not be done. And that's because as soon as it's exposed, it's going to oxidize, it's going to take in moisture, it's going to turn into something completely different, and it's not going to work anymore. So we picked it because if we can make this work, then we can make any drug work. We can pick a drug that's a lot smaller, we can encapsulate it much easier, and we won't have a lot of those issues that we would have here. And that's basically what this is showing. It's basically showing that we can encapsulate the cerium. We're not seeing those extra peaks. It's not exposed. I'll go into a little bit later. I'll show some images on what that exactly looks like. But for our in vitro data, we actually have what is basically just cell viability. So this is just no treatment, so just cells growing on their own. We have a plain polymer dressing, and then we have cerium nitrate. It's not been spun, it's just regular cerium nitrate. And we have no real differences. All the cells are living, they're fine, they're happy. So when we add in these dressings, this is kind of going to partner with those spectra that I showed. The coaxial spun results show no effect. Okay, the cells are still alive, they're still happy. Whereas the dual spun, when you mix in your drug, they're exposed, they immediately hit the cells are going to die. They're not happy. It's because you're hitting them with too much drug. You're not encapsulating, there's no release profile. It's just basically you throw it in and then all of your drug is in there at one time. And this is going to be almost like a shock therapy. It's if someone came in for a treatment and you give them a week's worth of drugs and you give it to them at one dose. So we're trying to prevent that. So this data, this is going to be where we hit some of the limitations of the type of study we're doing. So we're doing cell viability, but for those of you that do cells, you know about 72 hours is basically the longest you really want to go without changing media. So in this instance, we have our cells sitting in media with the drug for 72 hours, which is not really how it's going to work in a real life environment, but this is kind of the steps you go through for showing how you're fabricating a dressing. So this is basically what the dressings look like. So if you look at the A and B, those are going to look somewhat similar. You have fibers, they're nice and cylindrical, and then for C, you see that big splatter in the middle. So C is the dual spun. This is how most people are trying to make dressings. They're going to mix everything in, spin it, and hope for the best. And really what you're doing is you're spraying drug everywhere. This drug is just exposed to the elements. It's not bioactive. You're not helping anything. You're not protecting anything. Whereas for B, what we're actually doing is making a shell. So if you can think of like an M&M. Okay, so you have the outer shell and the chocolate's on the inside. So that's kind of what we're doing here. We have a dressing. It's like your shirt, except if you were to break open one of those fibers, you can release drugs. And drugs could be in there and they could be protected. So this is going to be the loading capacity. This is basically showing that we can actually get drug in there, we can detect it, we know it's there, and we can verify that that spectra that I showed earlier is not saying we have no cerium inside our dressing. We do indeed have cerium, it's just protected. That's going to be coupled with this. This is just kind of a degradation. This is basically you take your dressing, you drop it in, and you get a release profile. Okay? So our main goal for this was to actually prove that we can make a electrospun hydrogel. Okay, so we used PEO, so polyethylene oxide. So it's a polymer that as soon as it hits liquid, it's basically going to gelate. It immediately is going to start breaking down, and it really turns into like a gel. Okay, so if you can imagine, instead of giving a random person a tube of toothpaste, and you give them a random number and say they need to use this random number for this much square centimeters of injury. Well, a normal person is not going to know what to do. So in this case, we give them a dressing, and it can release exactly how much they need for that dressing area, because as soon as it hits, gelates, and it's basically contained exactly to the wound area. This graph is basically just going to show that we can actually control this dose dependent-wise. We can add more cerium, and we can get more that's released. This is actually done in what's called a permagear, so it's a little more physiologically relevant. Basically, you're going to have a dressing, and then you're going to have liquid that is flowing underneath. And then you're catching what's left on the bottom. So it's a little more physiologically relevant than just dropping in a bucket and seeing what's in there. But that's basically all this is showing. This is showing that if we add more, we get more out. So this is a little busy, but really this is just our ex vivo study. So we're basically taking burned porcine skin, non-burned porcine skin, and we're trying to see what are the cytotoxic effects. And we're not really seeing any major differences for our coaxially spun dressing in comparison to any of our controls. So in conclusion, I mean, we were able to show that you can actually use electrospinning to encapsulate and kind of shield drugs or any type of moiety you want from the elements without doing fancy nanoparticles or microspheres. That's going to raise down the costs. So that means it's more likely to get pushed through to actually be used. Also, we were able to show that ex vivo-wise, we don't have any cytotoxic effects. Since then, we've moved on to in vivo studies, and we see that same trend. We're not seeing any cytotoxic effects. We can actually shield it from infection and so on and so forth. We're actually working on moving this to the sustained release portion. So we're using different polymer systems so that instead of releasing all the materials in 3 hours for the burst release, we can actually release them over 72 hours. So if you can imagine, service member, they get injured, they put one dressing on, they get an initial dose, and then it lasts for the next 72 hours. They don't have to do anything. It's continually giving them drugs. And then when they finally see their clinician, they have a jump start on their healing process. I mean, that's really what we're aiming for. So that's really it. Hopefully I can get you guys out of here on time. So thank you.